All right. Good morning, everyone. We're going to go ahead and get started here. I just want to first of all say thank you all for investing some time with us this morning. We've got some great panelists. I'm Taylor Rogers, by the way, with CCIG, and I'm gonna be kind of wearing a few different hats during this here presentation. So first and foremost, I'm an advisor, working with employers to help craft solutions and all that fun stuff as it relates to healthcare. Second, I'm going to try to be the voice of the employer as we speak with Connie and Blake here throughout the presentation. And third, I mean, we'll get to that here in just a second. Sorry about that. So we're going to be tidy. We're going to be to the point, as we go throughout this presentation. I do have Davis Snedeker manning the chat. So as you have questions for our panelists, please feel free to place those throughout, and he may pop on and off throughout to make sure that those questions are heard. So spent the first part of this year on the road, meeting and speaking with some of the top minds in healthcare and health insurance. And there was just a steady drumbeat that I kept hearing. This is one of the some of the more bearish data that I've seen throughout my career in the industry. And as I started to get a little cynical and a little jaded and a little pessimistic, I had to reflect on that and say there are things that we can do about this. I know that there are. And so what are those? And how do we get out in front of this information and be proactive with it rather than just let the world come to us? So that's the whole purpose of this presentation here. We've got a couple of predictions, and then we've got a lot of data behind those predictions, and we just want to unpack it for you. So I'm going to start by introducing our two guests here today. So first off, we have Connie Perry. Connie is a PharmD by training. She spent the last 2 decades plus in the pharmacy consulting space with huge names that you've heard of with Aon, Willis Towers Watson, Milliman, and PwC. And she is now the managing director for Ethica Pharmacy Advisors. So she is an independent pharmacy consultant working with large employers throughout the country, large and middle market. So that wanted to brag on her so she didn't have to brag on herself. I'm telling you, you'd be hard pressed to find anybody more capable and more equipped to handle some of the things that we'll be discussing than Connie. So Connie, thank you so much for joining us. And I've got one quick question so that you can introduce yourself and share a little bit with us. Why would an employer choose to work with an independent pharmacy consultant? I know that they feel like in a lot of cases that's what they hire us for, their advisors. So why a specialist? Why an independent pharmacy consultant?
Well, we'll certainly get into, thank you, Taylor. We'll certainly get into a lot of the concerns, obviously, in this particular space right now, being pharmacy. And it's not only the concerns we see on the PBM side, but some of the bigger houses of which I've worked at. My 2 big points were just misalignment. There's a lot of firms out there that are very much aligned with certain PBMs and coalition deals. And we think that that's not in the best interest of clients who really want to find the best PBM, and they're often transparent. And we know that space really well, and we think it's up to you as to who you want to partner with. And the second piece is really the fiduciary piece, right? The litigation that we're seeing against plan sponsors, employers in this country, by employees that have had to leave the pharmacy benefit and in order to afford their medications, because the way the plan was set up, drives to very high priced items. And so that fiduciary responsibility of, again, knowing who you're contracting with, how the contract is negotiated, that responsibility, is really best aligned with an independent consultant. So those would be my two reasons. Taylor, thanks.
Yeah, no, absolutely. And you just touched on something there that I think is really important that I want to circle back to. You mentioned coalitions, and I know that we hear a lot about that in the space. So we'll wait until we unpack some of the PBM complexity and we go over some of that information here in a bit, but I do want to make sure we circle back to that. So thank you very much for that introduction there, Connie. Next, we have Blake Allison. Blake is the CEO of Employer Health Network, leading efforts to align high-performing health systems with self-funded employers, deliver cost-effective patient-centered care. Blake has previously served in leadership roles with Baylor Scott & White, Quality Alliance, and Southeastern Health Partners. So Blake is a wealth of knowledge, both from the provider, the hospital side, as well as now from the employer side, working with self-funded plans. So, Blake, thanks so much for joining us. And I guess to tee you off, we'll dive into some of the massive challenges facing community hospitals here in just a bit. But how does EHN, or the Employer Health Network, improve life for both health systems and for the employers that you represent?
Yeah, good morning. Appreciate the chance to be with everyone. And Taylor, thanks for hosting it and your group, and certainly appreciate your partnership. Yeah, it's a great question. So I'm going to try to say some pretty simple things as we go through and unpack it. I mean, I think one of the key messages that I always want to make sure folks hear is that the health systems are open for business. They understand the issues that are happening, but we've come to a place where the health system is marginalized away from the employer through all the various things that we can unpack. And so I think there's a want to sort of find ways to cut through that. And so at EHN, our mission is really to try to bring the two key stakeholders, you and your employers and the employers, and the health systems are delivering the healthcare closer together. And there's a want to do that. And when they do that, we're finding that there is incredible value when you start to eliminate some of the middlemen or middle processes or middle companies that are starting to separate the two stakeholders. And so really what we do and the way we try to improve life for both is to be able to help that transaction happen at scale and repeatable, but does feel like and is meant to be the employer, the consultant working on behalf of the employer and working at least a few steps closer to the providers, and the providers certainly feeling like they're working a lot closer to the self-funded employer. And again, I just want to they're open for business. To pretend they don't understand the challenges, I think is something we'll unpack, but I don't think that's right. But also, they are right now stuck behind some partners that they don't trust as much. And so it's creating a lot of noise and dissonance in the market. So that's what we're trying to do. I think we'll unpack more of that, but definitely trying to make you all the key stakeholders come closer together.
That's great. And we will dive into some of the financials of regional hospital systems and some of these folks that are just really struggling to stay afloat at this point. So I think you'll understand why EHN has such a great mission, both in terms of providing employers with affordable access to healthcare for their employees, and also doing right by the health systems in our communities to help them stay in business and able to care for you and your family. So tactically, that could be a very complex issue, and EHN simplifies it a great deal for our clients. And so, yeah, we'll tackle that here in a bit. So I want to give you a very quick shell. We're going to do our very best to make this entertaining. You guys can help with that through the chat. And as I thought through this material and in kind of the order that we want to go in, the best approximation I could come up with in my crazy brain was that this is going to be somewhat similar to an episode of Dateline. Dateline always starts with a trigger, that piques your curiosity, followed by this really terrible tale of, usually homicide or something to that effect. Then they try to end on a high note with resolution. If it didn't have a high note, it'd be on Unsolved Mysteries or America's Most Wanted. So we are going to follow a similar flow here. We're going to share some data that, like I said, is some of the most bearish data I've seen in my career. But then we're going to give you the positives that you can do and the steps that you can take as an employer. So with all of that said, let's move on here. So these concerns, the reason it says actuarial concerns, there was a gentleman that had the privilege of speaking with a few months back, and he owns an actuarial data and research firm. And he laid out this presentation very beautifully where, from an actuary's perspective, keep in mind, these are the people who set rates and rate tables that ultimately determine what you pay for insurance. These are the cost drivers that are getting their attention, that they're making meaningful adjustments to in their calculations. So the first one is medical cost inflation. I don't think this is any secret, just across the board as consumers in America. We've got tariffs and fear of tariffs. We've got rising labor costs. All of the things, like everything in our lives, are getting more expensive, and medical care is no different from that. So that's certainly a piece that's very relevant. Another one is utilization and service mix. I've filtered out some of the really pithy data on this, but after the COVID-19 pandemic, where we saw a big dip in utilization, particularly for elective procedures, that has not only rebounded, but it has gone well above the trend line for the foreseeable future. So people are using the services, out there, whether it's orthopedic or oncology or, you name it. We're just seeing higher utilization. Higher administrative costs at insurers, hospitals, TPAs. While AI seems like a really great tool, and it is in a lot of use cases, we're not seeing it create the deflationary cost pressures on a lot of these administrative companies. In fact, the cost of labor and the cost of talent is as high as ever. And so we're seeing those administrative costs continue to go up, albeit not as significantly as the actual cost of healthcare. So that's something that they're keeping an eye on. Overutilization is primarily driven by physicians that are overburdened. They're seeing more patients than they would like to, and that is due to a number of things, mostly physician shortages. So when you have physician shortages, you've got physicians seeing more patients, and the quality of care has seen a little bit of a decline. When you see a quality of care decline, it leads to readmissions, complications, infections, additional hospitalization, all of that. If it sounds expensive, it's because it is. And then lastly, stop loss pricing. Without going too deep into the actuarial weeds here, if a claim goes up 8% to a stop loss carrier, it goes up about 16% due to a principle called leverage trend. So all you need to know is if we're seeing a 9% or 8% increase on medical care, they're seeing about double that, and that's causing more pressure within the stop loss market. So that is, again, all really, really cheery stuff, but we'll get to the beauty of this presentation that I listened to from this particular actuary is he ended it with exact, very specific recommendations, and I think you'll find them relevant to the guests that we have here. Okay, so prediction number one, we promised you two of them. We predict that trend is going to actually be greater than 9% for the year 2026. So as you can see here on the left side of my screen, this primary data, for 2025, the predictions by Aon, Willis Towers Watson, and Mercer ranged from about 6 to about 9%, which as you can see, the 7.7 and 9% are significantly higher than any other data point going back to 2014. It's a little bit of a runaway train. You can see that dip there in 2022, which was largely the come down from COVID, where I mentioned that utilization dropped, but everything going forward is an acceleration. They're higher than 2024, as I just mentioned, for all plan types. And then this is the big one here in the bottom right corner, prescription drug trend for outpatient, mostly PBM-filled drugs. The Siegel trend study, which we put a lot of credibility behind, has the prescription drug trend at almost 12%, with the specialty drug trend at about 13.3. This is for mostly inpatient, what we call J-code drugs that are administered within a hospital setting. So you blend these two numbers together, you're in excess of 12%, and we'll get to more of that later. Long story short, we've been used to 7-8% trend. We're expecting it in excess of 9. So what is driving this? Whew, a lot of things. The first thing we're going to target here is the carrier books want to perform at this line here in the middle, this target MLR of 85%. As you can see from Q4 of 2023 to Q4 of 2024, their books are performing worse, and they're all above target for the most part, with the exception of, I think United, where is it? United, yeah, they're just a tick above at 88%. So, and same with Cigna. So they're flirting with it. Everybody else is pretty well underwater. When these carriers fall underwater, they have a few choices. They can raise rates significantly. They can run you off by basically giving you an untenable renewal, or they can deny care and try to get those claim payments reduced. All of those things have trickle-down effects that are not great for employers. And the other thing here that I want to point out is these hospital contracts that they have get renegotiated. Well, if their book is running hot, they can apply that pressure to the hospitals in your market and make life harder on them by reducing their reimbursements to those enter Blake Allison and the team at EHN, trying to preserve some of that viability for the local hospitals. So again, all kind of a negative trend line here as far as the carriers are concerned. This slide here, I call this the cruise ship slide. It's a lot of data, so I'm going to do my very best to make this simple here. We are getting older, and our youth are sicker than they've ever been. They're more expensive than they've ever been. So the foundation of the U.S. health insurance matrix is basically that we have a pyramid shape, right? We have a few older folks that are driving costs, and we have a lot of young, healthy folks that subsidize the cost for the older population. This slide here, this graphic here on the left shows us that the baby boomer group demographic is starting to age into 65 plus, and we're seeing that population widen. They're living longer than ever, and they're also more costly than they've ever been. As an additional factor here, if you look at the bottom of this graph, those pink little lines, if you can see them there at the very bottom, we have a falling birth rate, and so the bottom of the pyramid is getting smaller. So where we've traditionally had this big, nice pyramid, it's now more like a pentagon shape almost, where we just have fewer young, healthy people to subsidize the growing elderly population. And in addition to that, young people are as costly and as sick as ever. As you can see in these data points to the right, 8.2% increase in obesity rates among age 20 to 44. Well, what does that mean? That means we now have folks that are living with high blood pressure, high cholesterol, diabetes for significantly longer than the generation before them, who perhaps, became obese in the age 40, 45 plus demographic. Now we've got folks that have been living with diabetes and hypertension for decades of their life. So that's a big issue, causing early onset cancer incidents to increase by 27% in patients under 50. That's a huge number. I mean, 27% increase is significant there, and we pair that with a 15% increase in stroke rate among patients 18 to 44. You can see why, when we look at the data, it looks like a train approaching a wall. It's all pretty negative. If there is one positive here, we've put it in green. The advancements in medical treatment have increased the mortality rate of early onset cancer patients. So we are able to treat them, albeit in very costly fashion, but we're seeing a higher prevalence at the same time. I promise it gets optimistic. Just bear with me. We've got to cover the reasons behind it first. So this slide will be very, very short. What I just want to point out here is that employment-based enrollment has decreased in real numbers from 2019 to 2023. So the last couple slides were numerator-based, right? We're seeing a growing gross expense for healthcare in this country. This is denominator-based. We're dividing it by fewer bodies. Not a huge drop-off, but 5 million people is somewhat significant when you're talking about a bigger number divided by an even decreasing number there at the bottom. So that's the only real point of this. We are seeing some of that go to the marketplace. We saw a lot of it go to CHIP, particularly when the COVID pandemic was in place. We saw Medicaid enrollment swell. So that's where they're going, but they're coming out of the employer population. And then finally, whoops, hang on. Computer's giving me trouble there. Finally, we have this, which is near and dear to Blake's area of practice. This slide should be pretty alarming. We have approximately 60% of hospitals in the US that are operating at a budget, either a neutral or a deficit. So 40% are operating in the red, as you can see on this chart here, and the median hospital operating margin across the country is 4%. So when we have 40% operating in the red, that tells us that 40% are at risk of closure. You can't operate in the red for a prolonged period of time. I think we all know that with our own businesses. And so what happens when these folks in the 95th percentile start gobbling up these folks down here toward the bottom? Consolidation causes prices, healthcare prices in a market to increase by about 30% almost overnight because they start billing for those services under the acquiring hospital's contracts, which they have more leverage, they have better reimbursements, the cost of care is going to go up. So it's really critical that we protect the hospitals in our community and do what we can to keep those open. All right. So that pretty much lands the plane on the medical side. We're going to move over into RX, and I will tell you this can get a little bit convoluted, as you'll see here in just a moment. Blake, Connie, anything from that first batch of slides that you want to touch on before we keep rolling?
I would just, to the slide you had a second ago, and kind of what we interact with health systems daily, certainly on a recurring basis through our partnerships. I think what you mentioned earlier, it gets a little bit not lost. I think one of the challenges for sure is on the government funded side. It's not so much that the reimbursement is a challenge, which it does, and those are different issues, and we're not here to talk, but it puts pressure on it. But what's happening underneath that is the complexity of the patients that are in the government funded are going up at a faster rate than they really know what to do with. So you've got this, this compounding factor of reimbursement that's somewhat struggling and fixed, and we can argue, the Medicare as a reference, but that's it. It is what it is. And then you have a patient population who's increasing both in volume but also in complexity, putting in incredible pressures on, the operations of a health system. And most of them, generally speaking, a large bucket of their day-to-day interactions are with people that are in government programs. The commercial population doesn't consume the same way. So I think we sort of look at reimbursement and think, oh, that's this issue, but you've got to kind of deal with this complexity issue that you outlined on the cruise ship slide that's underneath that not only is it just the member that's 65 needs this, that 65-year-old might have multiple, and Medicare's reimbursement doesn't keep up with that complexity at the level. So that is this double whammy. And then you mentioned the commercial piece. Oh, by the way, health systems, like all of us, are employers in the market as well. Their labor costs go up, their costs go up, and their ability to go to that government market and get more doesn't exist. So it unfortunately, it creates this unseen tax, or now seen, but a hidden tax on the commercial population. But they don't have a good protection from some of that. So that's why they're stepping out and saying, I got to work differently because I've got these pressures and I've got to deal with the commercial market in a more proactive stance. So I want to say, yes, we don't interact with a health system that's not dealing with some level of challenge, and we deal with some healthy ones, but they're still feeling like their slip could be just around the corner. Their issue could be just around the corner. I will say what's been interesting that was not such the case, I think, a few years ago. There used to be very strategic acquisitions. And that was something that we had in the 90s under the early 2000s, especially we saw lots of consolidation of health systems. And that was a very strategic play where health systems were becoming health systems. I used to be a lot of individual hospitals. They became health systems. Part of that was in response to the payers consolidating as well. What's happening now is, to where Taylor was going, is they're like almost having to acquire hospitals because they don't want them to fail or because they're showing up on their front door. And they're not as strategic as they used to be. And that's actually a problem for both sides, because they take a failing hospital, they've got to go fund it. Goes back to the reimbursement challenge they want from the commercial. They may not have viewed that as strategic acquisition. So I just want to, it has a double whammy in that that market gets impacted, but also the health systems may not even want to acquire, but they can't do without. So they take it on and it creates further challenge in there. So you have a very volatile provider environment, never mind the fact that the physicians are caught up in this as well. And I think that's sometimes scarier than the hospitals. Is I happen to live in South Carolina. I'm a native Texan. There's parts of this state where, told to me by physicians, shown to me, they get paid 50% of Medicare from Blue Cross South Carolina. That is an unsustainable number to exist. So what are they doing? They walk into the hospital and say, could you please, I can't make $56 an hour to deliver healthcare to people. So can I get acquired? So just wanted to touch on that. So you got a physician volatility coupled with the health system, the hospital volatility. And so definitely, this slide, I don't think is getting better in the near term, but it's putting pressure on commercial market.
Well, and we didn't include the slide in here at the risk of hopefully keeping everybody awake. I know it's tough to listen to me drone on, but you mentioned it right there. You know, you've got hospitals or providers, physicians in South Carolina that are getting 50% of Medicare. Guys, in real dollars, the Medicare reimbursement for a physician office visit, we have it on another chart, is actually lower in real dollars than it was 7 years ago, and it's about $32 for a visit. So you've got someone who is highly trained professional that's getting approximately what, $16 for an office visit if they're getting 50% of Medicare. And so you understand why they're trying to pack in 50, 60 patients a day so that they can make ends meet. And when you're a physician, if you're seeing 60 patients, 50 patients in a day, how engaged are you to offer great care? I mean, you're just trying to get through and keep your charts and notes up to date. So this is real and it impacts us. And it's probably why, if you've been to a primary care physician, particularly in a hospital-owned, primary care physician, you felt like you saw them for 30 seconds because you probably did. So it impacts all of us. Connie, anything that jumped out to you? I know we've got a lot of your expertise is coming up.
Just one thing, and maybe this will be on the positive side of things. The very next slide, Taylor, if you don't mind, just to point out, many of you are probably like, wow, the specialty drug and biologic trend is going down. And we don't normally see that for specialty, right? We've been witnessing double-digit increases over time. We are starting to see a little bit of alleviation because of the biosimilars that we have in the space now. And I'll talk a lot more about biosimilars, but this is the area of near generics for those specialty medications. And within the last 2 years, we've had Humira go off patent, and we've got great marketplace competition with that biosimilar. And then Stelara went off patent on 1/1 of this year. And so as the pipeline fills with biosimilars, we're going to have some alleviation off of the trend for some of these really expensive medications. So that's a little bit of a light at the end of the tunnel.
So Connie, this is where I put my employer hat on and promise to be the voice of the employer. If you're telling me that Humira's been off patent for over a year, Stelara's been off patent now for 6 months, and that these biosimilars exist and they're interchangeable, why am I still seeing them on my claims report? Explain that to me.
It's very PBM specific. And this is where we start to see the strengths and differences of the PBMs, because some of the PBMs, when they looked at their rebate arrangements, chose to keep those innovator products on the formulary despite the value of the biosimilars. And so that's an important thing to address, is who are you partnering with and why? I work with lots of clients right now where I do the math. I say, here's what you spend for Humira, here's the PBM's biosimilar, and here's what you could get it at through Mark Cuban. And guess why Mark Cuban's not in the network?
Because so he doesn't take kickbacks.
So it's an interesting exercise to help our clients with, in terms of understanding how to best contract, who to contract with, and making sure that your network is very broad and your members have access to all sorts of of good products. And some of the biosimilars are co-manufactured by the PBM right now, so they are not going to provide acquisition cost, and that doesn't get you to low net cost.
So guys, write this down. If you're seeing on your claims reports Stelara or Humira, you need to double click on that. You need to look into it. You need to understand why. If you're in a fully insured or carrier-based program, it's a pretty easy explanation, and we're happy to give that to you. But it's time to start asking these questions, because Stelara is a 6-figure expense, pretty much regardless of dosage. If it's on your plan, and the biosimilar is 10% of the cost. So it's definitely something that you need to look into and start to understand, how do we pay 10% instead of 100%. So we will continue on through that, but great points there, Connie. All right, so hang on, before I flash forward, Connie just touched on this, but we just spoke about it. We're seeing now double digits on both sides of the RX spectrum. One of the most astonishing numbers, which I have in a future slide, but I want to hit you with it now as well, is the average cost, or I'm sorry, the median cost of a new drug to market in 2023 was $300,000. That's up 35% from the year prior. So the innovation is a wonderful thing. We're going to touch on this here in a minute, but innovation is extremely expensive. And the way these patents, as Connie just referred to, protect the drug manufacturers and the drug innovators, we're just seeing absolutely unbearable and unsustainable costs in that innovation space. So we'll touch on that. Before, though, we dive into all that, I want you to understand, as crystal clear as this slide is, I mean, it should be clear to everybody, in my opinion, what a PBM is. And of course, that was tongue in cheek because a PBM is one of the more complicated instruments in existence, in my opinion. Their goal and what a PBM should do is aggregate purchasers for the sake of lowering drug costs and manage formularies to the bleeding edge of what's innovative and approved by the FDA and all that sort of thing to ensure that your members get the highest value drug when they need it. That's their whole goal. That's the reason that they exist. Unfortunately, these have become some of the most profitable companies in the United States of America because the convoluted nature of the pharmacy supply chain has allowed them to create upwards of 70 revenue streams that are baked into their business models. And so all of this that you see on this spread chart here is introduced complexity to obfuscate the margins that they create. I know that was a lot of big words, especially for my partner, Rich Haney. But bottom line, the complexity creates margin for them and it siphons value out for you. That's what you need to know here. Rebates, I want to touch on. I've got a slide here. Actually, I'll cover it in this next slide. Rebates, as you can see on this chart, the goal of a rebate originally was to get preferential placement on a formulary by the drug manufacturer. So I actually like to call these really sales commissions more than rebates. I go to PBMA and I say, hey, I really want my Humira to be on your formulary. It's a life-changing drug. It's a little bit expensive. The PBM comes back and says, okay, well, we don't want to include this on the formulary, but I tell you what, if you give us 30% of the drug cost, then we'll include it on our formulary. But I got to know what's in it for me. That's really kind of how the rebate game works in a very simplified fashion. And so, as you see in 2012, about 46% of a PBM's gross margin were rebates. Well, why have they dropped off significantly? Because employers have started, they wised up to it, employers and advisors, they started demanding that they get their rebates back. That's money that should belong to the plan members and to the plan sponsor. We're the ones paying for the bill for the drug, right? Well, all great things, start to work. And when they start to work, you have to, those PBMs aren't just going to accept making less money, the ones that operate like this. So as you can see, GPO fees started to take the place of rebates. You can see here on the screen, they've grown by more than 400% over the last 10 years. Because as employers have demanded rebates, they said, oh, we're going to start reclassifying some of this revenue and say, well, that's what it costs to run our GPO. We've got marketing fees and we've got all this administration that we have to pay for. So what used to cost 5%, or what used to make up 5% of a PBM's revenue margin or revenue makeup is now over 20%. So that's something we just want you to keep an eye on. Rebates were all the rage the last few years. They're starting to give away to GPO fees, which is why all of this shell game here that starts to happen. That's why you need someone like Connie, an independent PBM advisor that can keep their pulse on how the game is changing and make sure that you are not the victim of these things. Before I move on, Connie, anything you would add to that?
Yeah, I absolutely love this slide. I use something like this quite a bit because it is telling, but it's very true. When we think big picture now regarding how most PBMs, not all, again, there's a lot of really good transparent PBMs out there, but many of those that are still kind of working on that high revenue model, their focus for revenue right now is going to be on the specialty drug piece. And you know that if they own their own inventory. So I think it's really helpful when you're looking at who you're partnering with on the PBM side to think through, do they own their own inventory? Because if they do, they're controlling their own destiny, right? And it may not be the best acquisition costs that you can contract with. Mail order is not as heavily utilized, so that margin is going down, even though there's ownership again on the inventory side. And what I'd like to also point out on the spread, as you go through, we're at 11% right now. That's going to continue to go down, and it's going to go down because of regulatory concerns. So there are multiple states now in the United States for which it is against the law to actually have a spread PBM contract. The plan sponsor must contract in a transparent way. And I think that's a really good thing, but that leaves less revenue for the PBMs that are making money in that channel. And that basically means at the retail pharmacy, the contract that's transparent means it's adjudicating the prescription exactly as it's been negotiated between the PBM and the pharmacy, and the PBM can't take spread on those medications. So again, it's a good thing. It's going to decrease the margin there. And again, we're seeing more changes on the legislative side that's forcing that issue.
Connie, can you just give me a really quick, talk to me like I'm 5 years old. Explain spread pricing to me.
Sure. So the 5-year-old is throwing me a little bit, but spread means wherever you fill your prescription, that the PBM is making a bit of money off of that claim being processed. Historically, in the world of PBMs, they would make money on the retail network. So anytime your member, you go fill a prescription at a Walgreens or an independent pharmacy, the PBM would make money off of that claim. The true most favorable contract, let's say, contract integrity would be that the claim is processed exactly as it's been negotiated and as close to cost as possible. That's a transparent contract. Now, it's very hard. Again, if someone owns mail order or if someone owns specialty, to get to cost, right? Because they're controlling their destiny. That's why transparent PBMs that don't own but are contracting and you're getting exactly what they've negotiated is a more favorable, honest relationship. Again, more fiduciary responsibility in that type of arrangement. So spread means, again, a PBM is making money on the claim. Transparent means it's negotiated exactly as it was negotiated, and that claim processes it at 100%. Hopefully
Gotcha.
that helps.
Yeah. So if I,
Okay.
if I go in and I'm going to buy, prescription from a pharmacy and the ingredient cost is $5, I'm going to pay $5 plus whatever it costs to actually fill that prescription, as opposed to paying $50 and the pharmacy gets $5 and the PBM keeps $40 and all that.
Correct.
So got it.
Correct. Yep.
Awesome.
Yeah.
Awesome. Okay, so we mentioned drug innovation. We're going to hit just a few quick drivers here. I want to point out that this slide is good and bad, right? Like this is I don't even know how to pronounce this. Zuranolone, oral treatment for postpartum depression. This is this is a fantastic innovation. This is something that should exist. However, does a cost of $16,000 per treatment for an oral treatment of postpartum depression, does that work out from a value prop standpoint? I don't know. Does this particular drug here for Duchenne muscular dystrophy, hugely impactful? I mean, this is world-changing innovation, $3.2 million per patient. I think we all agree that these are things that need to exist. The question is, who's going to pay for them? And is this sustainable for an employer that's only spending $2 million to potentially have, on healthcare for their entire population, to figure out how to pay $3.2 million, for this particular treatment? It's a tough challenge. Again, oral treatment for cystic fibrosis, $370,000 per year. And that is something that's going to be taken year after year, at least for a time. So I mentioned this data point already, $300,000 median annual list price for a new drug in 2023 and 35% higher than 2022. Again, when I said bearish at the beginning, these are some of the data points that support that. GLP-1s, oh boy, we've simplified this a lot. I would say I get asked about this. Our team gets asked about this more than just about anything still. GLP-1s, for those of you who don't know, you've heard the Wegovy and the Ozempic jingles on TV and so forth. Donald Trump, famously called it the fat shot. These are the drugs that are taking off, being used in high volumes, and the average cost is roughly, somewhere around $1,000 a month for these folks on your plan in a traditional plan. We're seeing a 7.3% increase to total RX due just to these drugs between 21 and 23. And I will tell you that curve is accelerated significantly since that data point was created. And then I just wanted to point out this bottom right, corner, 58% of patients stop taking GLP-1s before they achieve meaningful weight loss. So when you look at this from a purely cost benefit standpoint, from a value judgment standpoint, can we say for sure that our company should cover these strictly for weight loss? And I think that's the question that a lot of employers are wrestling with because they are extremely costly. Connie, what are you seeing here? What are you projecting here? How are you advising folks in the GLP-1 space at the moment?
Yeah, so full court press. And you want to look at GLP-1s under two lenses, right? Yeah, the easier one is obviously in the management of type 2 diabetes. These medications, this class, the GLP-1 class, has actually been around for quite a while. It wasn't really until Ozempic hit the market that there was the recognition that, wow, folks are actually losing quite a bit of weight when they're on this medication for their type 2 management. And then obviously pharma took off with that one and said, maybe we should start actually producing meds and getting the indication for weight loss. And we're now where we're at. But from a diabetes perspective, I absolutely, recommend, and it's first line coverage at this point, this category for diabetes. But you should have prior authorization in place just to make sure that individual, may have tried metformin, which is a really low cost generic that works really well first, but that they are, again, truly diabetic. They have a high hemoglobin A1C, all of the components that would reiterate this is a good therapy for them. And then there's other ways you can manage the cost of this particular category. We're seeing things like making sure that you limit the drug to a 30-day supply and not a 90-day supply, like through mail order. With the example that Taylor just said, 58%, of folks don't stay on the medication. There's a pretty significant non-compliance rate with these. In fact, if you look at it, it's different between weight loss and diabetes, but at a year, only 52% of folks will remain on a GLP-1. For diabetes, it's only 40% if they're using it for weight loss. So to allow an extended day supply on a really expensive medication for someone that may not be on it in the long term is prudent. So we see changing on refill thresholds, just making sure that they're not over stockpiling, if you will, and filling early. All of that should go into the diabetic category. Separate and distinct is the conversation on, do we cover GLP-1s for weight loss? Nationally, less than 40% of employers are doing so. So the majority of employers are not covering this category for weight loss, and for multiple reasons. One would be if you don't have a program today in place that really looks at weight loss holistically as disease management, I wouldn't recommend coverage either. You want to have something contingent between coverage and active management. Then you're going to see more success before you just open it up for coverage, again, because of the significant cost associated with it. So I think it's definitely, worthwhile to ascertain your strategy and support of weight loss and healthy living. And I think the other thing, unfortunately, that's been a struggle for employers to make a decision is the lack of data. So there's been a few studies released. United Healthcare just released one that was a 4-year study of folks on GLP-1s for weight loss from 2020 to 2024. They showed no difference in medical resource utilization over time. However, you go to Novo Nordisk, who makes Wegovy, and they are publishing they're presenting 2 posters at conferences that do say ER visits are going down, hospitalizations are going down. So my fear is we're going to have conflicting data
Right.
instead of no data, and it's still going to be a big decision. So this is where you work with your advisor and really talk about overall strategy, and then make a decision regarding coverage of this class and highly manage it.
And 2 things that are worth noting here. One, these drugs did come off of the FDA shortage list. So the compounding options that were out there where you could get these drugs for $200, $300 a month compounded, and a lot of people were doing that. That door has now closed. Now we're seeing a prevalence of folks shipping them from Canada, which is certainly an option. And then these manufacturers have also created some direct to consumer pricing with no insurance. So essentially for cash pay patients, where you can get these drugs for approximately $500 a month directly from the manufacturers as a cash pay patient. So there are some windows and routes for folks that see the value. And I know that not everybody can afford to do this, but if members don't see the value in $500 a month for utilizing the drug, it becomes kind of a tough argument in my mind to think, well, I don't want to pay $500 a month, but I think the company or the health plan or all of my fellow members on the health plan should cover it. You can see why this has become such a hot button issue and why we get asked about it so frequently. It is a very, very murky area at the moment. So I'm gonna land the plane on the pharmacy side by saying we can't wait for DC and policy to come in and address all of these challenges that we're talking about here, because even the cabinet of the current administration is spread out on their perspectives, as you will, if you will. So, on the far right side, we've got folks that want to disrupt everything. Vaccines, I think it's pretty clear that RFK has been very vocal about that particular area, even some news in the last 48, 72 hours on that front. And then on the other side of the spectrum, we've got Dr. Marty Makary, Johns Hopkins surgeon, very well regarded, who's hugely, in favor of vaccines, when used appropriately. But I think the point here is we aren't getting to a consensus anytime soon that's going to result in meaningful policy that fixes all of this for us. Connie, we were talking about this the other day, the executive order that pushed most favored nation pricing, for the U.S., right? I think when we in the community and the industry heard that, it was almost met with laughter, because how does something like this even, how does that even work? It's a great concept. I mean, sure, it's going to look great in the New York Times, but what does that even look like? I don't think anyone has any idea what the first steps look like on something like that. So what is your perspective on that particular piece of legislation, the actual viability of it, and if you see any help on the way?
Yeah, no, we did laugh about it a little bit. So here at Ethica, we actually have an ERISA attorney that helps us track all of the regulatory stuff that's happening. And she always reminds me, Connie, an EO, an executive order, is not law. It is just a directive. So as much as, Trump came out and said, EO, most, favored nations, if you will, I honestly don't think that it could ever be implemented unless our country, which I don't see this happening, goes to a national healthcare system. If you go to a national healthcare system, you can negotiate most favored nations. That's what Canada does. That's what most of Europe does. And then you're talking one formulary across the country. That's when you can do most favored nations pricing. Our system is not set up that way. And so I think we have to continue to focus on what we're doing right now, which is, again, really trying to get to acquisition cost, contracting as best as we can with PBMs, knowing the PBM space, et cetera, dealing with, again, everything that's happening on a state-by-state basis. But most favored nations it's apples and oranges.
Yeah.
honestly. So I don't see that having much in the way of legs.
Excellent. The other one that I just want to point out, I think this is this bottom left here with Dr. Oz has openly criticized pharma pricing, but he's personally invested in major pharmaceutical manufacturers and companies. I just think there's conflicts of interest everywhere. And this is why we don't place a lot of hope in this particular area, albeit incremental changes can be very positive for us. And we do see legislative changes that impact our daily responsibilities all the time, and some of them have been very positive. Some of them have been more onerous for compliance and for employers than they've been helpful. So we'll wait and see on that front. But I did promise optimism. I did promise action items, and that's where we're going to go now. So I'm going to walk you through. I mentioned at the beginning the actuary that we listened to. His name's Nick Allen, wonderful guy. He gave us all the reasons that they were pessimistic, and then he said, here's the 3 things that I think every employer needs to do yesterday. Do it as quickly as possible. So let's move on to that. Number 1, data-driven plan management. You can't improve what you can't measure. You need to know what's happening under the hood of your health plan. And I would say if you are in a fully insured environment, most carrier-based plans do not give you the data to even understand what's happening inside of your plan. You may get some large claimant detail with a vague diagnosis. You may get your top 25 drug list, but you don't have any insight into the rebates generated for those drugs, what's being recovered by your carrier. We see the data as step 1. This is why when you speak with us, we're very, very biased towards self-funding when and where it can make sense, because we want to help you manage your budget as effectively as possible, return as much value as we can to your employees. And if we don't know where the dollars are going, that's a really tough job to do. Honestly, it's an uphill battle at best. The next is high-performing network strategies. Wow, it's almost like Blake Allison's on this call. Imagine that. So this was his second recommendation. You hear a lot of smoke in the market about direct contracting. I want to get my employer on a direct contract with this hospital system. I will tell you, if you don't have a pretty significant population in a market, good luck. You're going to have a hard time developing direct contracts without some scale in a market. And that's where Blake, and I'll let him elaborate a little bit on how EHN was able to develop their network. It's a cool story involving Whole Foods groceries, which we'll let him share. But that's a really powerful story, and this is a huge linchpin of plan management. And then finally, PBM optimization. Weird. We got Connie here. That's to speak to this exact area. So we're going to double click on these. I've got some questions I want to have them answer for us. But as you can see, these are the 3 big bricks as far as the actuarial perspective was concerned. So going into that, Connie, what's the biggest mistake or oversight that you see plan sponsors make when it comes to formulating a prescription management strategy?
Hands down, not having one. Sometimes I work with employers and, they implemented a new PBM a couple of years ago and they just haven't looked since. It's you're meeting with your vendor on a quarterly basis, costs are, rising. We really recommend you look at pharmacy every single year, because 10 years ago, it was 10% of the healthcare dollar, and now we're at 25 to 30% of the healthcare dollar. And it's important to diagnose. I always say it's very similar to, going to your physician for your annual checkup. He or she is going to review everything from head to toe, right? How are things looking? Is everything healthy? We do the same thing on the pharmacy side. You want to look and see, okay, number 1, how's the contract look? Is it stale? Is there room for improvement? You want to look at your plan design. How is it set up? Is it optimized? There's actually math behind how a pharmacy plan design should be set up. The differentials that you need to change member awareness and move them to lower cost items between a generic and a brand, for example. So looking at the plan design, looking to see what drugs are covered and what's not covered, and having those conversations. It's always amazing to me. I'll talk to a client and say, it looks like you're excluding these today. And they're like, I don't even remember making that decision, and we're adding coverage back in. So doing, the diagnosis, I think is really, really important, in doing that every single year so that you can revisit your strategy and have a framework for change over time. And so sometimes we'll say, this is what we should do for 1/1. This is what we're going to put, in queue for the following year. And let's readdress it. Let's look at the outcomes. So having a strategy for pharmacy is really, really important. And I think a lot of employers don't think of it on the front burner. It's usually on the back burner. So that would be my suggestion, is to make sure you actually have a strategy for pharmacy that you're addressing every single year.
So you mentioned an interesting data point there that, and we've seen it very much so, that prescription utilization as a total percentage of claims is up from 10, 12, 15%, years ago to now 30. I've seen it upwards of 50% of a plan's utilization. Guys, this is where the bodies are being buried right now. Connie just pointed that out. So having a plan and having a strategy is extremely critical. Blake, I've left you hanging for a while, so I'm going to hit you with a question here. So
no worries.
It doesn't matter if you're on LinkedIn. It doesn't matter if you go to an industry conference. You hear a lot of people talking about direct contracting. And in my experience, working on behalf of an employer, that's a lot easier said than done. First of all, to get the audience with the decision maker at the local hospital system to listen. And second of all, having enough belly buttons to make it at all enticing or incentivizing for them. Why would they give you a better contractual rate than they're giving to the Blue Crosses and the Uniteds of the world when you've got 250 employees, right? So tell me a little bit about how you guys approach this and how you offer more or less direct contracts and high performance contracts to the self-funded employer market.
Yeah, a lot in there to unpack, and certainly, the way we approach the market when we went to the health systems, one of the things that we had initially, and I think Taylor kind of led with this, is we did have a couple of large employers that were working with us that we could walk in and at least get us an audience. That was an initial moment, but frankly, as we moved out of the markets where that employer was, what we found, again, go back to earlier, there was this appetite for the health systems to want to work with employers. That was an easy sell. What was harder was, how do we do this at scale? To the point that you just made, Taylor, what they didn't want to do was say, if 100 consultants came to me with 3 employers each and they all on a direct contract, that becomes really complex for me to administer and understand, even on the health system side. So this operational component was a big deal. I think also what gets lost is, I think sometimes the TPA struggle, like, how are you going to reprice against that? Who loads those contracts? Where does it go? How do you make sure you reprice it the right way? There's this operational piece for sure. But definitely, we walked in and said, no, let us tell you how we can do this once structurally, but then attract and work with a number of employers who to you look like a single process, but it could be a number of processes behind it. So they definitely were locked in on us around the idea that we could talk to self-funded market. That was a key point. And number 2, we could create a transaction process that they understood and could scale, while still giving value to the employers without having to do each individual deal individually. I would say, even in the time I've been at EHN, for lack of a better word, the hardening of health systems willing to do sort of direct deals that way has started to increase. More saying, hey, we just can't administer this and we're getting it wrong. We need to do something different. So definitely, they're starting to feel some of that as well. Even if they stepped out early and said, let's go do direct deals, then they're saying, gosh, now I've got 10 of them and they're all sub-optimized. So that was definitely, the operational component was a big piece. The other side of it is, I am not the pricing expert inside EHN. We have someone, but pricing is really complicated. I wish it wasn't, but it is. 150 a Medicare, 180, that all sounds very easy intellectually, but when you actually get into the dynamics of the contract, you can end up moving in the wrong direction or the right direction almost on accident. And so, one of the things that also is just kind of inside the expertise that we try to bring is we're looking at the lens of the contract through that buyer side of what are they going to be purchasing. Because sometimes you can get a great contract, you think, on paper. When you go get to the actual pricing side of it, it may not be as optimized as you want. Simple example is, if you're in a market that had a teaching hospital versus a community hospital, 150 in Medicare is dramatically different between those two hospitals. You probably know that, it's fine, but you have to know that. But even the two community hospitals have different rates, right? So you have to know this complexity. Plus, you want to make sure track that pays you, it works well for the things your clients are going to be buying. So if I give you 140 here versus there, we find that we get really good rates on some stuff that gets bought a lot, and we get maybe a little bit what feels like reduced rates, but it's less frequent. We'll give on that because we'd rather have the high frequency items. So that's, really to me, it's sort of the contracting complexity and pricing is one reason that we were able to kind of exist and why it's going to be challenging for the market. And number two, we created this scale point for the health systems that said, gosh, if everybody just comes through one of these types of channels, I can scale this, I can do it over and over again. And so that's been a big piece, of how we've had some success.
So Blake, give me some orientation. You said numbers ranging from 140, 150, 180 of Medicare. I know all of us inside the industry can easily orient to that number, but let's compare that to a big national network, a logo that we're all familiar with. What sort of multiples of Medicare are we comparing to?
Yeah, when we get when we don't get a lot of payer data or actual allowed data, so what the contract's paying for the national carriers when we do repricings, but we certainly do enough anecdotally, and now we're getting into the MERF files. It's rare in a major metro to see a BUCA plan getting, in aggregate. So I know folks say, well, I got this getting less than 200% of Medicare.
Okay.
In aggregate. If you're below that, it's a rare, maybe it's a market specific idea where, they cut a deal with Cigna to go try to buy business and they did things like that. But we're rarely seeing things on a commercial PPO side less than 200% of Medicare.
So practically speaking, if I'm an employer and I'm evaluating this and I say, okay, it sounds like your high performance network is built around specific hospital partnerships in my market. What I'm hearing on the front end of that is, so you're telling me there's certain hospitals and certain providers that are going to be out of network that might have otherwise been in network with a PPO. So in exchange for potentially a smaller high performance network, what sort of savings can I expect if I decide that I'm willing to forego some of the hospital access in my network, in my market?
Yeah, we see two different buckets. One, we see usually a strong double jump. I'm going to say 15 to 20% reset of the baseline so to go live, right? So if you bought something for $100 before you go back into that facility, you're going to pay 85 or $80 for it, and that's just going to reset. What we're finding to be interesting in our multi-year clients, which we like all of ours to be, but not everybody is we're also creating stability over time. And we're doing that in a couple different ways. One, we're very big on the steerage aspect of our network. So people get healthcare inside a machine that knows what it's doing and it's coordinating. So we're getting people into primary care, making that easy, et cetera. Number two, though, really what's more interesting is probably in 6 months from now, we're going to get a message in the news about X health system fighting with United or Cigna over their contract, and they want it to go at 5 or 6%. We have very limited or small escalators that just kind of deal with COLA or cost of living, normal things, but our contracts are incredibly stable. These are meaningful partnerships. They don't come to us and say, you know what, I think we need to up you by 20, 30%, which is what's happening on the other side, or we go through. We're a vehicle for them to relate to you, Taylor, and your clients, right? Not a vehicle. They're not going to fight with us like they do. So we also create this stability over time because most of our contracts are auto renewal or evergreen, and they're not coming back to us saying, hey, even during the COVID or post-COVID and the inflation, we did get one health system, frankly, asked us for a 5% increase, which for us is pretty big, but they were asking the market to the BUCAs to do a 20% increase. So our delta split faster, right? And they actually got that. They were big enough to sort of, that they got that, right? And so that stability is also what over multi-year, we're seeing that trend start to flatten because you've got stability in the network. And on the pricing.
So if I'm hearing you there, the network really does two things. One, it gives me access to all the specialties that I would need, albeit maybe not with every single provider group or hospital that's in my market, but I do have access to high quality specialists, that meet the parameters of, access, right? Like justifiable access. In exchange for potentially fewer, the network's going to help me get to the right side of care so that I'm getting healthcare in the most efficient way possible, because we all know that, I think most of us know anyways, that outpatient services are a lot less expensive than inpatient services. So site of care matters. And then also the underlying contractual rate is not only lower out of the gate, because again, we've shrunk more or less the number of people we're willing to contract with, but they're also more stable. So I think it sounds like there's kind of a multi-layer value prop here, and in addition, a partnership with a community health system that takes an interest in you and your employees.
Yeah, well said. And I think we have to own that there's some disruptive or maybe some other options out there that potentially put the member and the employer a little bit at odds with the health system. And I think over time, as that grows, it creates a challenge. And we're trying to flip that over as well. Still get good value to the health system or to the employer, but let's not maybe make the health system who's been here 100 years, going to be here 100 more years, feel adversarial towards the relationship, but embracing.
So give me a very quick snippet on how Whole Foods got down this path in the first place, and how you guys bolted onto their buying power.
Yeah, it's an interesting thing. It's actually kind of funny. I wish it was more complex than this, but honestly, they wanted to do some stuff different. They were with United Healthcare, and United told them no, they wouldn't do it. I mean, it's almost the same. They went in and said, "Hey, we'd like to create a simple, like our own kind of network with our own kind of providers, and just kind of do something." And shocking, United's like, "No, we don't do that," and so they lost the account. And so they came to us and said, "Hey, could we do X, Y, and Z?" And for us, absolutely, we can do a lot of different things. And so it was really as simple as they were not ready to leave the payer. The payer sort of pushed them out of the door, and we've seen that multiple times now from there. And then they said, "We want to create a curated network that's partner with specific health systems, engage with them, mainly in Austin and LA, which were two of their largest, obviously corporate headquarters in Austin, and then Los Angeles is their largest single market of just density of employees." And they said, "We just want to start working across the aisle better than dealing with this." And we walked, and they found us. And they said, "Hey, can y'all do this?" We said yes, and that's kind of how the story was done. Had United said, "We'll help you," we wouldn't exist today with Whole Foods. I think we'd exist anyway. I think we found that there's a different strategic angle, but certainly, we wouldn't exist in the same way we are. So that's a lot of what I think, Taylor, kind of embedded in what you were saying, and sort of this middle bullet is the other thing is the networks, and we have rules, but the networks are owned by the payers. The payers want to keep things in their world. By having to have access and play that, you don't have the flexibility to do things that you want to do, to use benefit design as a member engagement, to use benefit design to steer. I mean, I see on their steers matters. They have rules that are all about protecting themselves. So it was also a mechanism for us to say, keep access, but then we can be more creative in the plan. And I think Whole Foods definitely wanted to do that. One side example on that we've really been proud of, huge issue with people going to primary care in their population. Whole Foods is super interesting when you read their book. At the end of the day, it's $10 an hour people putting bags of salad on a shelf, and that's their population. Super high levels of ER use, or urgent care, lack of primary care. So Whole Foods woke up and said, "Hey, if you go to EHN's primary care doctor, $0. We're going to remove the barrier for you to get primary care. Pay for other stuff, but $0." And we've seen that number start to go down. It's fantastic. We're finding things earlier. Members are getting care they want. It's a lot for an $8 an hour, $10 to pay $150 out of pocket for a visit. Zero means something. So we're seeing they've been able to do that. Those are things you can't do all the time and where you want, because you can't isolate the network, right?
So it's not just the network, it's also the underlying plan design. And it's really, as Charlie Munger always said, show me the incentive, I'll show you the outcome. You create positive incentives within the plan, you get the behaviors, then not only deliver high quality care, lower the cost of care, and get you really in a stable place. So
real quick,
that's
there's
great.
A question in the chat. Tell
Yeah.
It's a really good one. It said, "What benefit eligible headcount would you recommend looking at direct contract?" So it kind of goes back to your size question. The cool thing about EHN is our smallest group is 2 employees, and our largest group is 7,500 employees. So I would say in the world that we've created, you don't have to worry about size anymore. The 7,500 employers getting the exact same pricing and value as the 2-life employer. And that's intended. So there's not really, if you want to go engage a large health system, you better have a few thousand committed EEs. And even then you might struggle with some of the health systems to get it. So if
So
you want to
this
go
is
direct.
this is a 2 second, and I appreciate you sharing that because I tried to pull up the Q&A and the questions aren't loading. Thanks, Microsoft Teams. So I'm glad you were able to see them. And Davis, by the way, if there's any other pressing ones in there, feel free to pop them in and get us focused on those. But if I put my advisor hat on for a moment, I would elaborate on Blake's point to say there are two issues. One, you have to be able to contract with an independent third-party administrator. Because the big major network administrators are not going to let you put EHN in place to compete with their network. So that's part of it. And in order to do that, you have to be able to get a stop loss contract that makes sense. And so what we would usually say is you probably need roughly 60-ish on the plan, and that can vary depending on how many dependents you have enrolled and what your total spend is. But it's usually about $1 million of total spend is where we can start to make the math work to say, hey, we think a stop loss contract here is actually a good decision versus, if it's going to occupy 60% of your fixed costs is going to be a stop loss contract. A lot of times we would tell you that juice is not worth the squeeze unless you're just really passionate about righting the wrongs of injustice here. So that's my 2 cents as an advisor. I'll take that hat back off now.
We do have one other question in the chat here, Taylor, and this
is
for Connie. Connie, are you seeing employers work with a separate advisor exclusively on RX?
Yeah, I love that question.
And if so, at what size? Yeah, does that
and I just responded to it in the chat too. So thanks for having us direct there. Absolutely. Quite a bit of our business is working strictly on the pharmacy, but we work jointly with your other consultant on the medical, if you will. So I work with competitors all the time in terms of if we're negotiating savings or changing plan design, making sure that the underwriters and the actuaries that you may be working with on medical are in the loop. So we're all one big team kind of working on your behalf. So certainly work separately on pharmacy. And in terms of size, for us, data is key. I know we keep talking about that, data-driven plan management, but for pharmacy, that's critical. So really the only requirement we have is we do want to work with self-funded employers because I can actually access your data and your contracts and do negotiations that way. If you're fully insured, it's just hard for us to act on information because we don't have access to data. That's not to say, though, we have some clients where we've moved them from a fully insured environment to a self-funded environment and helped them find the right PBM partner. But by and large, our clients are just self-funded, but there's no minimum threshold.
Yeah, to Connie's point, in the fully insured world, it's you can have data, and in certain cases, like in Texas, we have pretty good access to data. But unfortunately, you can't do anything about it because you're working with folks that give you a take it or leave it pharmacy contract. So you do need that flexibility. So that's a great point there.
Yeah.
Any other questions, Davis?
No, that's it. I think
okay, cool. I've got a couple more just because for Connie and Blake here. Blake, just practically speaking, before we land the plane on this, if an employer says, man, I really like this idea of direct contracting, and I've got 200 folks that are in and around Austin, Texas, but I do have this one satellite in Poughkeepsie, and it doesn't look like, EHN has a presence there or a full-blown network there. So what would I do in that scenario where I've got, a pocket of employees that just really don't have access to the EHN network?
Yeah, I think you hit the one first, which TPA you partner with in your TPA matters because they have access to specific networks. What typically happens in those scenarios is simply the members who are in the EHN environment or in EHN markets will see EHN either as their only network or part of their network strategy. And then the other ones they'll have access to a traditional PPO. Some will do depending on or some other solution, reference-based, PPO, whatever the consultant or the employer wants to do. So we just basically are able to work with most of our TPAs to carve out that population. They see it, the folks in, I use Paducah, Kentucky, use a different word. Those over there would just see a different solution for sure. And so that's typically what we see. Some of our large national employers have been able to do a true tier design, like we're in our markets. They can have EHN as a tier, but that's pretty complicated. You have to have the right TPA, the right scale to do that. And if you're not in one of our markets, you just see the traditional, normal plan on the PPO. So all that to say, that's how most do it. Some will go as far as saying we're going to make everybody on a PPO, but in the markets where EHN is, when they go into the open enrollment, we'll create it as an option. But if you're not one of those markets, when you go to open enrollment, you won't see the narrow network as an option. So there's a base plan, and then there could be a side by side in certain markets. So, but the consultant matters. Certainly the TPA matters a lot on what they can bring to bear. The last thing I would say, and I've been trying to learn this, we're not the only company that does what we do, and we work a lot with other folks. I think the other thing is take a few minutes. We can certainly help with this. We have some other partners that help. Like there might be another network solution like EHN in that market. So I think we don't do a good job as sort of knitting that together, but there are some ways to say, gosh, I could do a regional narrow network, a high performance network in that area, do a regional network here, and everybody has the same type of design. I'm just using different, networks with different, logos on the ID card, and then using something like a First Health wrap as people may cut across that one time it happens. So lots of ways to do it. I think it's simpler than people think, but it does require, some thinking.
So if I'm hearing you and also adding my own twist to it, you're not confined to the one logo. If you work with EHN, if you have different needs in different pockets, you can slap a different logo on the card, have different plan options available. And another question that we've gotten, because we do have clients with EHN today that have been extremely successful, have performed really well. There's always the question of, well, man, I've got these 30 employees and their spouses are just up my HR team's rear end. They need to have this gastroenterologist that they've seen for 10 years. They won't go on EHN because they're not in the network. If you have enough employees that fit that bill, you can offer a base plan with EHN, high performing, low premiums, low deductibles, all that sort of thing, and then offer a buy-up and say, hey, if it's that important for you to have this national PPO, then you can buy up to the national logo. The reason we force them to pay more typically for that plan is because we as the plan and as the employer are going to pay more for those claims. And so it's only natural that you should pay more for the premium when the cost of care is higher, especially when we know that EHN is going to provide them with all of the specialists, all of the access that they need. It really becomes your buying preference at that point. And some people are willing to pay for that. Connie, last question that I've got for you as we near end of time, and maybe anything else that comes to the Q&A is obviously on this slide. Let me see if I can go back here just so we've got an accompanying visual. Sorry, it's slower than it should be. Where are we seeing the PBMs bury the bodies? This chart only goes through 2023. So you mentioned specialty pharmacy, a little bit earlier, but we know that this is a constant game of whack-a-mole. That's why you exist. That's why pharmacy consultants are so important. So where are we seeing this game of whack-a-mole, and where are we seeing the bodies buried? And what are the innovative strategies in the middle market that you're deploying to achieve, high performance?
Yeah, so great question. Thank you. So one of the things that this particular slide doesn't address is that the outpatient pharmacy benefit isn't the only place, right, where drugs are being processed and there's a cost dynamic. One of the things that's really important to recognize is when you're building out your pharmacy strategy, you need to look at what's happening under medical as well. There is a very large and growing amount of prescriptions that are processed under medical where there is a savings associated with that as well. It never surprises me when I do talk to someone and we're looking at the medical claims of specialty, and I say, are you getting your rebates on those? And they're like, huh? So those claims are still submitted to the pharmaceutical companies for rebates. And if you don't ask, you will not get those. So there's value in rebate contracting. There's value in looking to see where those claims are being filled, because we see different sites of care have lower costs of care as it relates to the pharmacy or prescription drug mix, if you will. So really making sure that strategy also includes medical, because there is a revenue stream that the health plans have and the PBMs have on that side of the benefit too. And don't forget about it, because sometimes we want to actually move those claims and not have them covered under medical and have them covered under pharmacy. So there's a lot of strategy that can be learned from looking at pharmacy holistically, medical and the prescription benefit. So I don't want to diminish the fact that we haven't really addressed that today. And I think that's part of where, again, the bodies are still buried. And then again, I would say in terms of innovation, it really is looking at partnering with disruptor vendors. We see auction houses now really taking specialty drugs out to bid, getting really good aggressive discounts. Those work in conjunction with the PBM. We see vendors that will produce a very different formulary, but it's a low net cost formulary that can again be placed on top of a PBM arrangement. Different types of contracting we've talked about. Do you want to get acquisition cost? What type of contract do you have? All of those are really kind of where we're focusing our efforts for change, for innovation, and managing the pharmacy benefits. So some really good ideas that I think a lot of folks don't realize, we're starting to uncover and learn from and are seeing good success.
What about, there's a lot of folks out in the market that are bringing drugs in from Canada or from the UK. What is your particular take on international?
So that's a lot to unpack. I will say, right now it's approved in Florida. There's lots of state by state legislation getting approval, but it is not necessarily approved in the US. So I have to say, due diligence, it's not necessarily in compliance, but certainly we support clients that are having their members voluntarily work to re-import medications. The key here is that every vendor has different capabilities. They're using different pharmacies in Canada. There's different drug lists. You need to make sure you're doing your due diligence in assessing whether or not on a net rebate basis, which cost is actually lower, because we are finding that even in Canada, the prices without the rebate could be higher than what you're getting in the US. So just, again, being educated regarding which drugs you're going to want to re-import, how members get access to that, how that's incented, does require a little bit of homework.
Great points all across the board. I think the one thing you hit on, I want to double click on, is voluntary. In the states where it is not fully approved, it needs to be a voluntary, not a compulsory program, one that employees have the say in whether or not they participate. And you can incentivize, but you cannot force, in most markets. So,
100%.
And you pointed out a great point too. We have pricing files on all the list prices and the delivered to door prices on drugs from Canada. And in some cases, you actually lose money, like even on just a gross basis of going to your local pharmacy. So not every drug is economical, but some of them are hugely economical. So actually doing the work to see what's in your drug mix and then how you engage those patients that you find opportunity to save the plan 10 grand, 15, 20 grand a year. What's your strategy for actually contacting those members, presenting them with the voluntary option to do this, and then letting them decide ultimately which route they want to take. So, guys, I can't thank you enough. We're right here close to time. I don't see anything else in the Q&A, but again, I don't have full visibility there. So if there is, Davis, anything else there?
All set there. Yep.
Awesome. Guys, thank you so much. Have a wonderful rest of the day. I hope that there was that this did come across as an investment of time. I hope you learned something. And if you have any follow-up questions, feel free to reach out to myself. I'm happy to connect you with Blake and Connie if you want to talk more with either of them. And we'll talk to you next time. Thank you.
Thank you so much.
Thank you all.
Nice
Thanks so much,
guys. Bye-bye.